Okay, so I'm going to do a quick presentation on using ultrasound in anterior shoulder dislocation. So outline of the presentation, I'll explain why I think ultrasound is useful, and then we'll talk about the technique of actually doing it, and then talk a little bit about the evidence of whether it works or not. So why ultrasound? There's a few reasons. I think one, speed. So when a patient comes in with a dislocated shoulder, the longer it's out, the more the muscles tense up and the harder it is to relocate it. Some ER docs will just reduce the shoulder based on their physical exam. But I think the ultrasound is a good adjunct. It's just right there. You can take a look and confirm your suspicions. And then portability. So a really useful thing that I've actually used myself is if you have to sedate a person to get the reduction done, you don't want to have to wait for them to wake up to go back to X-ray to confirm that it's back in, and then possibly have to resedate them if it's still out. So it's right there bedside that you can do it. And then it's also just as accurate as X-ray in the right hands. So those are three good reasons. So the technique for using it. Trevor, remember when I took pictures of you with your shirt off?
I forgot about that.
Yeah. Yeah. That was, I didn't have that on later. So you can use either the linear or the abdominal probe. The more I read about it, you're actually supposed to use the abdominal probe in adults. It just gets better windows. So you're going to put the probe horizontal, and you're going to try to go just below the scapular spine on the affected shoulder, and you're always going to have the probe marker facing lateral. So it doesn't matter which side you're on, just have it facing lateral. And then, so this is the anatomy that you're going to see. You're going to be looking, can you see this?
Over to the right. If you go over to the right.
So you're trying to get the probe right here below the scapular spine. So you'll be looking through the infraspinatus, and then right below that you'll see the scapula. And then you're going to try to slide the probe over until you get to the glenohumeral joint. And you see the humeral head and the glenoid. And that's when you know you're in the right spot. So this is what it looks like on ultrasound. So you've got the infraspinatus, the scapula, glenoid, and humeral head, all labeled there. So that's the view that you want to get. And if you want, you can have the person rotate the shoulder, like internally and externally rotate, and you can see the humeral head rotating within the joint. Can you see it? Yeah.
Come on, try that.
Ooh, there you go. Okay, let me show you one more time. So this is the view. This would be the scapula, the glenoid, and then if you have them rotate back and forth, this is a normal humeral head in the joint. So abnormal, so in an anterior dislocation, the humeral head is going to be pushed anteriorly, obviously. This is what it looks like clinically. Honestly, sometimes these can be a little hard to diagnose clinically, but you should see, the two big things are you should see this flattening here where the humeral head was, and then sometimes it's tough to actually feel the humeral head in the axilla, but really the flattening is the biggest sign, and then they'll be holding their arm flexed and internally rotated. So when you look with the ultrasound, you're going to see the infraspinatus here, you're going to see the scapula, you're going to see the glenoid. The humeral head should be right here, but if you look, it'll be anterior. So the probe is coming from posterior, and this is anterior here. Humeral head will be down here. And that you're seeing here is just the dislocated joint. Another reason that this is beneficial is you can actually use this view to do your intra-articular lidocaine injection if you want. I actually have not had a lot of success with that working, but you can always try it. So then you do your reduction technique, whichever one you want, and then you can use ultrasound to confirm that it's back in. So this is an image, the shoulder's out, and then you can confirm that it's reduced afterwards, especially if the patient's sedated. Oh yeah, this is a picture I found when I was looking at reduction techniques, and supposedly if you're out in the woods by yourself, you should just hug a tree. And if it doesn't work, then at least you hug a tree. So the evidence, There's 4 studies on this. 2 of them look at this posterior view, which I think is the easiest. I didn't even look at the other 2 ways of doing it, which is like an anterior lateral view. The 2 studies that looked at how accurate it is with the posterior view, one, they gave ER doctors a 30-minute lecture, and then they just told them, go out, and if you think that a patient has a dislocated shoulder, ultrasound them first, mark it down, and then confirm with X-ray. That study had about 100 people, and they were 100% sensitive and specific. And then another study did it with college students, and they gave the college students a 30-minute lecture and then 30 minutes of training, and then they just put them in the ER, and they said, anyone with shoulder pain, just go ultrasound them. And the college students also were 100% accurate. Obviously, these numbers are too good to be true, but it's the only data we have. So it's 100% accurate. You'll never miss. So overview, use the linear abdominal probe, use the posterior approach, go out laterally with the probe marker lateral, fan out laterally until you see the joint, and then you can use it to confirm reduction. That's it.
No. I did so good.
Whoa.
I can't slow down like that.
Just the magic of icons.
I just have a comment. I mean, I think I agree with Charles. I think the post reduction is probably the thing to use this for. I don't know if you read anything, but I guess the reason I usually think about getting an X-ray is because of the mechanism pulmonary fracture.
Yeah.
With it. Yeah. So me for ultrasound, I'm not able to do that, but that would be the only thing I'd be worried about that you're missing, like a concomitant fracture or something that I would not want to start pulling out.
Yeah, for sure. I think it's most useful for the patient that comes in and is like, I dislocate my shoulder all the time. Right. I know it's out, and you're just like, all right, let me just confirm really quick, and then you put it back in.
Or like younger people with.
I was also thinking about catching people who come in and say they dislocated their shoulder, but they're like even more paid before, and then you just ultrasound them, and you're like, oh, it's not out.
Yeah. Go to the pub.
Yeah.
But I agree, it's really important, like, in addition to looking at your physical exam for the dislocation, I usually just palpate up and down the humerus really well too, and if there's going to be like an obvious fracture, then usually they'll have actual tenderness when you're squeezing your humerus, and if it's just dislocated, they don't. I do sometimes get the X-ray though anyway, if I have any concerns.
Yeah.
And it's true, like what Murchison's saying, for adult patients, you usually use the abdominal probe just because there's just too much soft tissue or muscle in the way most of the time. You can use the linear. It's great, linear for sure in pediatrics and some thinner, but usually abdominal probes need to hear that.
And then, like I said, the mechanism is a big decision for me to the X-ray. If they just put their arm up and their arm and it popped out, you don't probably don't even need it.
Yeah.
But if they got beat up,
Right, yeah, like a football game.
yeah, a football game, they got assaulted, they're gonna have all this stuff. Yeah.
Okay. Break for a second before everybody falls asleep. Like
I never did any of those pictures.
I was going to say, you the other ones, right? That's all.
The ones
We're going to meet for a second, everybody.